A very good morning to all of you, and thank you, Stanley, for the kind words and for the introduction. So these are kind of the World Health Organization, Ghent University, ICRH, and where I work currently. The Aga Khan, that is my affiliation. Short biography, medical training, OBGYN, here at my Ghent University. So I live in Kenya, but for me it's great to come home from time to time and to still be linked to the university and to ICRH. I worked as a politician, was a member of the IERG, and then director of the World Health Organization's Department of Reproductive Health and Research, where I retired last year to go to the back to my roots, to Kenya, where I started research in 1986. At that time, the research question that I was sent to help to address was, can women be infected with HIV? We didn't know. In 85, 86, an AIDS patient was a male, white, mainly homosexual in the West. So times have changed. Anyway, some of you have heard my presentation yesterday and you know about the Millennium Development Goals, but I just want to reiterate that in 2010, Secretary General did kind of evaluation of the Millennium Development Goals to see that 4 and 5 are lagging behind, going slower. And that's why he created this platform, Every Woman, Every Child. And that is still existing. I come back to that later. Really to catch up with the health, a global strategy for women and children's health. This is the global strategy developed in 2011. Many initiatives under the global strategy, just a few others were born too soon, because something that is also neglected is what? Preterm birth. A lot of mortality, a lot of morbidity is due to children who are born too soon. So at the MDGs, where are we with the global strategy and the EVEC, the Every Woman, Every Child? More health of women is higher on the political agenda, more stakeholders, more money, more global initiatives, more innovations, more research, and accountability we discussed already this morning, but has it also reduced child mortality and maternal? Yes, unprecedented in time results in reducing child and maternal mortality and morbidity, but going too slowly. We haven't reached MDG 4 and MDG 5, but we can learn what has worked and what should we do better. So these are the lessons learned from the global strategy. In a country or in a setting where you have political leadership, things are moving faster. I'm not going to name or blame or shame countries, but I think you all can think of countries that have reached the Millennium Development Goals despite the same economic, same geography. Just to name one, in Africa, Rwanda has reached MDG 5 and MDG 4. There are others, but strong political leadership and commitment, multi-stakeholder partnership, accountability, and then the global movement. But what could work better? The leadership in countries. Country plans, national plans, coordination with existing activities, and I think the UN is the first one that has to do better. Because within the UN family, a lot of initiatives are launched, good things are done, but there is a few coordination. Also donor communities, they don't coordinate. They all say we are going to coordinate, we don't start something new. First thing they do, they start a new secretariat, a new field of work. So there is, and they all want to coordinate, not to be coordinated. There is a lot of fragmentation and so on. So better coordination also in research and action, and I think that's where this network can also play a role together with others. But at the end of the Millennium Development Goals, we say no woman should die while giving life. Still 303,000 per year. No child dying of stunting. No newborn born to die. But every year 2.7 million newborns are dying. And 2.6 stillbirths, a neglected tragedy. So there is progress, but much slower than what we were hoping for. So now we are in this new, you have seen this already, and we also have a new global strategy for women, children, adolescent health. You have seen this picture already. Please read it. It is an interesting document, and it's not only anymore about surviving, but also about thriving, about well-being, and about transforming what? Systems. Because we have to work with a health system. There are too many of these vertical programs and plans. We have learned from the good HIV example, but we have to integrate the vertical priorities into good health systems. All this is published in the BMG and the global strategy with all the evidence, so please go and read it. And the guiding principles of the new SDGs and the new global strategy are country-led, but many countries don't really provide leadership. Although we see some progress, universal, sustainable, human rights-based human rights are more higher on the agenda. Equity, evidence, partnership, people-centered, community-owned, accountable, and humanitarian settings. All important values that we should unpack. Of course, we don't have the time to do that. But let's not turn the page and say now we have to move to other areas. We have to. Much more comprehensive, but don't forget that maternal mortality, morbidity, stillbirths are still there. So we have to broaden the scope, but not stop working what we have done. Showed this already. And again, I showed this yesterday, can't show it enough, saying that there is not a disease. Of course, here in my own hospital, women are also dying. In Belgium, women are dying giving birth. But how many? We have about more than 100,000 deliveries per year in this country. We have about 5 to 6 women who are dying. You cannot prevent everything, even with the best care. But a country like Kenya is many more, and some areas in the world are still up to 2,000 per 100,000 deliveries per year. So what are the major causes of mortality? We know them. Hemorrhage, bleeding, hypertension, infections, and depending where you are in the world, HIV can play a role, but look at 27% are indirect causes. So that brings us to the NCD agenda. Diabetes, anemia, other indirect causes that are important. Same for the newborn, but I'm going to focus because of limited time to the maternal deaths. I mentioned already this morning, I spent many, many years in Pumani Maternity Hospital, the largest in the world, in Kenya, where years ago we had, what do you see here? I'm going to show you a lot of pictures. What do you see here? A nurse who is doing what? Cleaning, washing, gloves. Because we hardly had gloves. The nurses, the midwives. So we had to use and reuse and use them again over and over. This has changed. But this was, for me, the first maternal mortality. A girl, 14 years old, who came to the maternity. She was an AIDS orphan, the eldest of a family of 6. Gone to town with family, with siblings to survive. And of course, 14 years old, she got pregnant, alone, no money, living in Matari Valley, and having a hard time. She was 3 days in labor. The uterus had ruptured, the baby had died. She was still alive and she arrived, but we couldn't save her life anymore. And then you just have a white blanket covering. We had them like every week, maternal mortalities. And the other ladies were just giving birth. You see blood stains, because one day in 2, we didn't have water, we didn't have electricity. Those things have changed. Still a lot to be done. But investing, because when do most women die, pregnant women? They can die during pregnancy, they can die postpartum, but most of them die in labor. So if we can improve quality of care in childbirth, we have a triple and even a quadruple return on investment, because we will reduce the number of women dying, the number of newborns, number of stillbirths, and if you have better care for preterms and for babies with asphyxia, during labor, you can prevent long-term disability. We invested a lot. Also, our students are there in Pomani, and we did a lot of charity. You won't save it with charity, but philanthropy to rebuild and refurbish and rebuild the operation theater and labor ward. But this is also a daily reality, because 100 deliveries a day, and the stillbirth rate is at least 2%. Now, the global community has decided also to give more visibility to stillbirths. And we have we have this Lancet series that I showed already yesterday, 2.6 million mainly in low and middle income countries. And here you have the highest numbers. Of course, we are not surprised, they are also the highest populations, but there is a ranking with countries where they are in the percentage of stillbirths. And it's good that this comes more and more on the agenda. 10 of the countries account for 2/3 of the stillbirths, as well as for the majority of the maternal and the neonatal deaths. So we need to measure, because if we don't measure, we don't know, we cannot improve. But of course, measuring is one thing, and our Director General at WHO always said, what you don't measure doesn't get done. That's true. On the other hand, it's not because you measure that it's get done. So we have to intensify that as well. When do these babies die? Half of them during labor and delivery. How do we call them in many parts of the world? Fresh stillbirth. It's a word that always shocked me a bit. It's like fresh vegetables, fresh salad, fresh stillbirth. It means the baby looks fresh, and the mother came in labor with a baby that was alive, but delivers a stillborn baby. Whereas a macerated stillbirth, it is going process that is taking place during pregnancy. So globally, we have 1.3 million stillbirths, and a stillbirth is a very good indicator of what? Quality of care, because they shouldn't die. If they are supervised in a maternity where you have decent supervision and quality of care, they shouldn't die, or at least not that many. So what do we need? What do we have in most settings where I work? We have this, how do we call that? The fetus. But what do you do if you don't hear the heartbeat of a woman in labor with fetus? Well, you try this. You ask for, give me the Doptone, the Doppler, the Sonicate. In most of the settings in Kenya, we don't have that. Ultrasound, we don't have. So what do you do if you don't hear the heartbeat? Could be a stillborn, could be just a difficult position, inshallah. So now there is a lot of technology, and we are working, as I said, with the private sector to support simple smartphones. Don't have to be iPhones, but smartphones with, everyone has a smartphone. Everyone has Coca-Cola and a smartphone. Even if you don't have, in Kenya at least, and in many countries, it is a way of paying. With your phone you can do financial, so everyone has a smartphone. So what if we could, and we can, just make sure that there is a kind of a Doppler built in, so that's what we are trying to develop now, that all healthcare providers, even women, have smartphones. So we have worked also with the global community about where are we with the rates. There was a bit of confusion about the rates, but now from WHO and the UN there is kind of aspiration for the new Sustainable Development Goals for 2030, that every country should at least reduce their maternal mortality by 2/3 from the baseline. And no country should have more than 140 per 100,000. We still have a long way to go in some of the countries. If you are now at 2,000, or like even 360 like in Kenya, it's in 15 years to get there. You have to do a lot of planning and efforts. And the global maternal mortality should be at less than 70. And the same figures are there for the neonatal mortality and for the stillbirth. So no country should have more than 12 and globally less than 9. So that's good. This is aspiration. Do we know what to do? Do we have the instruments to implement? Yes, many. And I'm just going to show them quickly. This is work from WHO, Aga Khan, a partnership based on lists and so on. This is a package of minimum interventions. If you can implement this, it's based on, look, 3 years review, over 50,000 papers, a lot of evidence, a lot of work. This is, ladies and gentlemen, countries, what you should. So we have instruments. We have more than this. We have a recent one that I was happy to co-edit from the DCP3, a volume on reproductive, maternal, newborn and child. Not only what to do, but also how much does it cost. And that is work done by the World Bank and partners. It's called the Disease Control Priority, and this is the history. In 1993, there was one booklet from the World Bank, the UN and other partners and stakeholders. What are the disease priorities? So many years later, 2006, the second volume, a little bit more volume. And now, we are now in 15, 16. Now there are 9 volumes. So this is the one that we produced on RNMCH that has been launched, is available on the websites, and has a number of like costing is there, interventions, effectiveness, burden of disease. So this is, I'm going to show you some packages, but it is a tool that can help countries to budget, to make their priorities, and to know what works and what doesn't. Again, you have seen this. So if now we look at our own work, and I'm not going to go through these tables, this is just to show you how we did it. What kind of interventions can be done in the community? What should be done at primary health care? And where do we need hospitals? So, and of course you can modify in your own settings, but this is management of labor, management of when you have complications, what should be done, and we have costed this and analyzed as an evidence base for all the interventions. Applying these interventions for maternal, newborn, and child health could be, we also did the modeling of course, prevent more than 2.6 million deaths per year. If you have, including stillbirths, maternal deaths, and so on, if you apply these packages. We also looked at costs. I'm not going to give you the figures but the most cost-effective intervention is family planning for reducing maternal mortality. The second one is investing in labor, in childbirth, number 2. Then of course there is also antenatal care, postpartum, child, immunization, everything is there. But the interventions with the largest effect on labor and delivery that can have a major impact. Again, the stillbirth picture, almost 17% could be avoided if you work with community platforms. Then you have the primary health care and the hospitals. Just to show that we didn't only look at the mothers, but also at stillbirth, newborns, children. I'm not going to read them all, but these are interventions proven benefit. Clean birth kits, corticosteroids, preterm labor, antibiotics, and so on. All this is published in the Lancet, so you can read the big volume, or you can just have the summary that is a publication in the Lancet. Now my third part of my speech, and then there is one more with pictures, is about quality of care, because we know what to do, but quality, and it has been said already this morning by Chandra, is really something that has been neglected in the MDG thinking and we should invest in now. So we have at WHO, when I was director, we started the initiative of thinking with the other departments about what is quality of care. How do you define? And we made a framework, and that is also published in the British Journal of Obstetrics and Gynecology last year. And so here again, you see a number of statements. We have to include also the indirect causes of maternal mortality, but also preterm birth, asphyxia, intrapartum related causes. And quality of care reflects more than just medical guidelines and staff that is trained in applying the medical guidelines. It is more than just the medication and the equipment and the supplies. Of course, you need good physical infrastructure, you need all this. But then there is also a very important component of respect. Because, as was said this morning, abuse in pregnancy and in labor, mainly in labor, happens everywhere. I was shocked. I was pregnant myself when I started working in Pulmonia. And one of the things that I remember is because there is no epidural anesthesia, there is no pain killing. So women in labor, the scream, the primal scream, times 100, you know, it was a high volume. And we were so used to this high volume that we were rather kind of suspicious when a woman didn't cry. Somebody who doesn't make noise anymore, maybe like the woman who died, if you are too far in shock, you don't cry anymore. So crying or screaming, the primal scream, when I came back and worked in my maternity here in Ghent, I was worried the first week because there was no noise. Nobody was screaming. You know, a woman who screamed once or twice, she was offered epidural, so it was silence. And I was always worried by the silence. So, but what I've seen many times as well is women who were screaming and didn't behave during the exam, were slapped in the face, were really treated with disrespect. And not only by the doctors, by the midwives, by the nurses, it was a kind of common culture. It still is a bit, but I think many people who are in reality see that it's not only Kenya, it's everywhere. So we have kind of developed the essential care guidelines. What do you have to do in case of this? We have to drill the staff in the medical intervention, but also make sure that their attitude towards the patient is different. So more human, supportive environment, the rights component is all built into the model. But what is quality of care? It remains difficult. So the WHO vision, in fact, we have worked a long time to have a definition. And it is now here the extent to which healthcare services provided to individuals and patient populations improve the desired health outcomes. And in order to achieve this, health care needs to be safe, effective, timely, efficient, equitable, and people-centered. This is the best definition we have now, but it's still work in process. So if you want to modify it, write to the WHO. It's still, and that's all the definitions, of course, what does it mean, safe, effective, and so on. All this is in the publication. The good thing is that here in the model, this is provision of care. And usually, a quality of care model starts from what the doctors offer, right? Not how the patients experience quality of care. And that's what we try to balance. Not only the checklist, is this available, you know, do you have water, do you have IV drips, do you have ABC? This is for us the easiest. But how do people experience this? There was a whole journal discussion today in the newspapers about women who are now complaining and forming a group. Yes, they had a cesarean section here somewhere in Europe, but nobody told them why and how. So the communication was poor. This is also the framework. And this is based on the work that was done also on Every Woman, Every Child. I'm going to skip this. One thing I want to say before I go I close on before I go to the pictures, is about something that also needs our attention. And this is this. C-section. There was in the maternal health series in the Lancet 2 months ago, there was too little, too late, and too much, too soon. All right. Why do we all do cesarean sections? I don't know countries presented here. China. What is a cesarean section rate in China?
Big variation, I think so. That is somewhere is 18% and somewhere is 14 and 15.
Yeah. And who is doing the cesarean sections? Doctors and midwives. No?
Assisted by
Assisted, yeah. So, in other countries, I don't know whether, yeah?
In Morocco, we have 16%.
16.
But in private clinic, it's around 29%. And it's gynecologists, the doctors. But we are aware about this because 16 in public health, in public hospitals, but in private hospitals it's 30%, 29, 30%.
Yeah, even in India also same situation is there. If women goes to private hospitals, she's more likely to have cesarean birth. And because it's commercial, they get more money out of that.
Is that you? I'll come back to that.
Same thing in Ecuador, for example, in the public system, there's around 30% of C-section made by gynecologists, but in the private sector is really higher than 44%.
And why is that? Who is guilty to these epidemics?
I didn't do research on this, but I was talking with a professor and she went to Brazil and she told me that it was crazy that women sometimes ask in Latin America because it shows your social status.
Sure. That's why I'm saying that's very good. It's not the only one. Everyone points at the gynecologist, yes. You know. But even in settings where there is no difference between fee for a C-section or for us gynecologists, it's much easier to do a C-section. And there are even colleagues in UK who are now calling for 100% cesarean section rate. Much easier. All your patients come in 38 weeks with music and theater. You do one section, you have a cup of coffee, you do the other one, and you go on with your life, with your work. No night work, no weekends, much easier. So for the gynecologists, it's great. The women, more and more are asking it. And to my big surprise, what we are trying to kind of push back, and it's the women who are saying now what I'm part of a kind of consortium who are trying to kind of reduce. So now the big ones against us are the women's rights activists, who are saying I have the right to decide on how I want to be delivered. I want to keep my honeymoon vagina, I want to have my cesarean planned, I want to, and so on. So for the women are not on our side. Well, of course there are different groups, but I mean, it's the last 10 years. Then the hospital managers, they're so happy to do a cesarean section because then we can just have our midwives and our staff in the morning and there are almost no deliveries. Family is happy because the husband who takes 1 week of leave to be there with the wife and he is waiting for the due day, nothing happens, he has to go back to work and then the baby comes. And so everyone is happy. Why do we make noise? Well, I think we should make noise.
And I think age of marriage is late now and we have more women that can have one baby and it's love this
Sure. But even as you were saying in Brazil, for example, or in many, in my own hospital where I work now in Aga Khan, it's up to 50%. So I'm trying to push back, but it's not easy. And it is social status. We have to change that. Before, long time ago, who were the women who were giving breastfeeding? Initially it were the poor women because the rich ones could afford to buy formula. Then it changed into the way the rich women, they can afford to be home and to work and so on. And it's the women who work in the factories who have to, they don't have time for breastfeeding. So we can have shift of paradigm, but I think we have to stress all the disadvantages of C-sections because they will be done increasing preterm, increasing many things that are not good for bodies and babies, but it is difficult. So with WHO we also made a new thinking what should be the national C-section rate, and it's actually confirming, but with more evidence and we need to do more research. A country that has a C-section rate of less than 5%, women will die and babies because of lack of access. But more than 15, you don't have any advantage, you don't gain. So now, what do we do as researchers? We know there are guidelines, there is a global agenda, we know we have the instruments, we know what to do. Many countries, financing is better, GFF was quoted this morning, is still a problem, but we as researchers, we need to focus more on how can we know what works, why don't we do it? The implementation. So this is kind of very quickly effective interventions, implementation and enabling context is the key to success. Getting to how and the implementation sciences, how do we put it in place? Improvement sciences, how do we make it better? How do we make our sonic aids better and our ultrasounds and so on? Getting to the how, this is the system science, creating this enabling environment, because we know enough in some settings, we have good maternities, affordable, available, and women don't go. Because the mother-in-law is the one who will decide on what happens with pregnancy. The owner of the child is the husband, but that's a man. So the one who then takes custody is the mother-in-law. So she will tell in a lot of settings whether you are allowed to go to deliver in the hospital. Then you have to work with mothers-in-law. I mean, sometimes it's religious, cultural, whatever, but think globally, act locally. So implementation research takes a lot of, looks at the context. How come that interventions are successfully implemented or not? And that's what we need to focus on. So this is the final slide on that. To avoid this kind of settings, I've seen this as well. You have skilled attendants. So then we have to have a skilled attendant at every delivery. Yes. But if you have a skilled attendant who goes and delivers there, sorry, it won't make a difference. Right. So now I'm going to show you pictures. This is also Puani maternity. There is never a problem with bed occupancy. There are always 2 or 3 women in one bed. One of the women in labor. This is another maternity, another country. This is in India. So I'm just mixing the pictures, but I show them because they are great pictures taken by a good friend of mine who is a journalist photographer, and we should have brought her book. She, what is it called again, Emily? Birthday. So the title of the book is Birthday, and she went to 19 countries, from Brussels, China, Siberia, Africa, everywhere, and she has beautiful pictures on the birds. This is the classic Pinar fetoscope. This is in India. The primal screen. And this is what we call, what our midwives are calling GAP, gentle assisted pushing. But it's not only done in Africa. Ukraine, you see the same attitude. So the midwives, they are very good, and we need the midwives, and we are happy that they take the lead in a natural birth. But we should also change some of the behaviors like this. This picture is also striking because there are 2 women. Why are they have a green gown? Why is that? They are waiting for theater, right? But they have, this one has 1 stick.
2 sticks.
And this one too.
Another.
What does it mean?
They may be.
married? Not married?
She is pregnant and the child is alive. So there are two people to take care of. She is pregnant, but the child has died. So there is only one. They should. Oh, it's good. Maybe it's a good system. I don't know. It's better than no indication. But this is in India. Everyone is welcome. This is Pomani again. Now there is progress because the new labor ward, the neonatal, the very little ones have more chance to survive. Education is given on how to breastfeed preterm babies, which is very difficult. They don't suck. Happy mother with the baby. Same one again. And that is my favorite. This is the harvest of 1 to 2 hours in Pomani. All the nice babies, so they are put together, and then the mothers, they leave the labor ward with the babies, most of them alive and kicking. So this is my presentation again. Go to the Every Woman, Every Child website and see how we as a community can contribute, because we can make a difference. Yes, we can if we care, but one of my favorite is, it takes two to make a child. It takes a village to raise a child, and I think we are all part of that global village.